It's always a pleasure to welcome Professor Gagandeep Kang to any venue, especially this one. He's been at the Division of Gastrointestinal Sciences at CMC Vellore for many years, has very shortly before this moved to another position with the Gates Foundation. She is India's best-known vaccinologist, also known for the development and trials of the rotavirus vaccine. In a sense, she's also functioned as a conscience for those of us who are interested at the intersection of public health, governance, etc. And is one of the very few people who really works at the intersection of basic sciences, applied biomed, and public health. So I'm very interested to be able to listen to her on these questions of where does AI fit into this larger context of equity and public health.
Thank you, Gautam, and thanks everybody for being here. Just to let you know that you're all guinea pigs in my new experiment. I changed roles about 3 months ago. Next week, I'm going to be retiring after a 32-year career at the Christian Medical College in Vellore. But for the last 3 months, I've just started a new position with the Bill and Melinda Gates Foundation. Now, through my entire career, when I've talked to people or I've given talks, it's always been from a perspective of, I'm a researcher, I'm here to talk to you about what I have done. And, my team built this, we tried this out, we had this question, we figured out how to solve it. Now I'm in this really peculiar role of being at an organization that's way, way bigger than my research group, my institution, the community that I have worked with so far. And I'm still trying to make sense of it. But since this was about machine learning in health and in disease, I really wanted to have the opportunity to think through with you the direction of travel that the Gates Foundation is taking. So the way I've structured this talk is to talk to you about the principles and an overview of potential opportunities in global health, not in clinical medicine, and then tell you about some experiments with an organization that we link to in many, many ways. It's probably one of the organizations in health that has the most data in the world. And that is the Institute for Health Metrics and Evaluation at the University of Washington, which annually produces the global burden of disease studies. Then I'd like to talk to you about a recent call for proposals, which was around funding AI initiatives that are led from low and middle income countries and trying to solve problems there. This is a pilot program, and this is one that I'd really like to hear about. And finally, kind of my thoughts on where we are and where we might go. And I'd welcome inputs at every point. So if we look at the principles that the Gates Foundation has developed, the idea of the foundation, and everybody who knows the foundation hears that they always talk about all lives have equal value. The idea being, what do you do to promote equity in the global environment? Does the foundation go about it the right way? I think everybody has questions about the approach and the outcomes. But the intention is to try and promote equity, where every person has the opportunity to live a healthy and productive life. So now thinking about AI, and particularly with ChatGPT last year, one of the things that the foundation is very focused on is cool technologies. What are we going to do with the latest cool technology that we have? And this was one where the fit with global health was very evident. The problem was, how do you navigate this space with a view to benefit and minimization of risk? Because this is an environment where the potential for doing harm through a lack of understanding or a lack of data is really very high. So the principles, the kind of virtuous cycle that is shown here is the way the foundation wants to try and operate in order to be able to leverage this potential for global health. First, come up with the core values. Think about not we will design for low-income countries from Seattle, but how do you actually co-design? What kinds of approaches should be taken? Proceed responsibly, monitor what you are doing, address privacy and security, and build for access and be transparent about the process. So if we look at the framework for what can be done in healthcare, it's all across the chain. There are some components of this that might be mattering more for high-income countries than they do for low-income countries. So for example, if you look at claims processing and coding and billing, that is something that really matters to a system that has HMOs that provide much of the healthcare. But if we look at population health, at surveillance and prediction, risk management, thinking about interventions and where those interventions could be targeted, these are areas that really matter to global health, and our ability to bring tools that allow us to move rapidly, move responsibly, becomes an added value to the functions that are shared by people who want to protect population health. There are other components of care that also matter, but each of these can be broken down and developed as a separate approach. So if you just take the area that I'm really familiar with, if we look at disease surveillance, what really has been done, there's a very nice paper by Brownstein in NEJM, and that talks about what are the kinds of functions and what examples already exist for our ability to be able to do this. So if you look at early warning systems, you can look at processing of news sources to identify outbreaks. If you look at pathogen classification, you can look at how do you automate malaria microscopy and diagnosis. Risk assessment, here there is, I'll show you that, a paper that looks at if you have very limited tests, how do you decide where those tests can be deployed most appropriately? If you want to look at sources, where do you do genomic tracing? How do you do genomic tracing of COVID-19? Similarly, for hotspot detection as well as for tracking and forecasting. So in surveillance, the opportunities, if you have the right data systems and the ability to access that data in real time, there really is a lot to do. As Gautam and pretty much everybody will tell you, the lack of access to data in LMICs is the biggest thing that holds us back. And that's why when we think about building for the future, the one thing that we have to do is build an environment where people trust us with data. And that is not easy. Especially, it's hard enough in a country. Can you imagine different countries cooperating and collaborating with each other? It doesn't really happen. And the pandemic treaty that the WHO is working on at the moment is trying to solve that, but it's not going to be an easy fix. So this is what I had pointed out, which is if you want to do border surveillance and you have a limited number of tests available to you, how do you decide when to use those tests? So they used information on origin, demographic information, and when people came in to be able to build a model that told you who was low risk and therefore did not require a PCR test and who was high risk and required a PCR test. You still wound up with a category in the middle where the information was insufficient to be able to categorize into low or high risk just based on the model itself. If you look at other approaches as a microbiologist, this is really important to me. I don't know how many times I've taught medical students that accurate measurement of a zone of inhibition will determine whether your organism is susceptible or resistant to an antibiotic. And it's not as simple to do. You would think measuring, a diameter was easy. It really isn't, and especially if you have slightly fuzzy lines. So this is a tool that allows you to look at being able to estimate and then interpret that data into whether the organism is sensitive or resistant to a particular antibiotic. So these are the kinds of things where if you don't have deep clinical and technical expertise, you can provide a tool that helps you bridge that gap. And then if you start to look at models, and here I'm transitioning into the kind of work that we've done with the Institute for Health Metrics and Evaluation, is thinking about what can we do if you have data sets to get more faster than we have had before. And for that, the two things that I learned from listening to IHME for 3 days was that prompt engineering, learning how to have the right question was really important. And then to try and figure out what constitutes reasoning so that you refine the questions that you are asking. So if we look at all of the approaches that are being taken, there are lots and lots of tasks that can be accomplished if you have these kinds of models available to you. But there are also problems. So I thought what I'd do is show you 2 stories that have been proposed in global health. So if you look at people who are doing HIV peer coaching, telling people in Africa what needs to be done, providing them with guidance about when they need to be tested, when they need to take a pre-exposure prophylaxis, what kinds of prevention options they have. The idea is that perhaps you could think about tailoring the guidance that is provided to underserved communities so that you then don't have to depend on people to do that for you. Another example is looking at Mozambique, where you have a malaria endemic region. Could you look at real-time diagnostic support and treatment guidance where you don't have to wait for an expert opinion to decide who to treat and how to treat? So if we look at opportunities like this, this allows us to address issues of inequity and access based on the fact that if you look at low resource settings, you don't have people, and you always, but always have a shortage of what can be used for testing and for treatment. So the more efficiently you can do that, the more rapidly you can do that, the chances of being able to address problems in global health are greater. But there are lots and lots of pitfalls, and the problems really are these 2 that I've highlighted here. One is that you can have systematic biases because the data that you're using is not really fit for purpose. If you're getting data from the wrong sources, making decisions for a different population, you're likely to be going down the wrong path. And then for people who don't understand a subject area, how do you find out whether there is or is not a hallucination, whether this actually makes no sense? Is there a more efficient way to do that? And for global health, where you're going to be putting these tools into the hands of people who might not necessarily have a lot of training, this is going to be very important. So moving now to a couple of experiments that were done with IHME. I have to tell you first about IHME. How many of you have heard of this institute, place? Excellent. Some of you have. You know what the budget of IHME is? $90 million a year. You know how many people IHME employs? Currently 600 people whose only job it is to produce global burden of disease estimates. Okay, so you have $90 million, you have 600 people, you have computing power like you won't believe, you have interactions with Microsoft, you can call up Bill Gates and tell him I need more money anytime you want. Okay, IHME has been a global resource for a long time. IHME produces these, basically what they do is, if the whole envelope is 100%, then what percentage of deaths or mortality or morbidity actually can be ascribed to this particular cause. Now that sounds simple, but it really takes a lot of information to be able to put it together. And IHME has access to data sources, to published data, interactions with governments, countries, etc., and does a brilliant job. WHO now uses IHME estimates to be able to say this is how big the burden of a particular problem is. So about a year ago, IHME was asked to look into the possibilities of using AI to automate some of their processes, with the idea that can we generate results faster? Can we do it with fewer people and at lower cost? And IHME did a series of experiments, and I'm going to just describe two of those to you. One of them is when you need to synthesize information, one of your sources is the literature that is out there. So if you look at particularly, IHME uses systematic reviews because they are well summarized, well evaluated information. So in order to do a systematic review, they have to look at tens of thousands of research papers, and this can take a lot of time. So they decided that they were going to look at what they could do to make this process faster. As you can see here, if you have 80 systematic reviews published every day, you can imagine that for every field, there is a lot that needs to be put together. So the problem was the global burden of disease study is founded on making sure that there is a systematic review and incorporation of all available data on disease and risk burden. And then there is a checklist, which is called PRISMA, which is used for assessing the quality of the systematic review itself. And PRISMA compliance is quite difficult. You need two people to review the paper. You need a third person to adjudicate. It can become quite complicated. So is there a way to do it faster? So this is an estimate of how long it takes to do a systematic review. First, you design the review, you publish the protocol, you conduct the searches, you screen the titles and abstracts, you then read the full text articles, you decide which ones to include or exclude, you extract the data from the included articles, and then you analyze the data. And this is before you've written the systematic review itself. So this is how long it takes. Can you do it faster? So the way they set it up was to see, can you do abstract screening with GPT? Can you get a full text screening? At what time do you need to bring in a human expert? So what is excluded is easy to decide. What to include actually requires a human review. Based on that, you have final inclusion into the paper. What they did was create a web app. And if you look at a single paper, this is the way it worked. There was actually a review that was done by GPT that summarized the information. And then all of this could be put together in a table, and then the table got the human review about what was included or excluded. This actually resulted, if you look at the classification, it didn't do badly at all. So there is the opportunity here of making things a lot faster than it was possible previously. So IHME has almost 100 people whose only job it is to do systematic reviews and extract data from systematic reviews. So now if you can automate this task, it just becomes easier to do that. The second example I wanted to give you was using verbal autopsy in the global burden of disease data. So there are a number, one of the problems is what WHO had originally proposed was that for every death where you wanted to understand the cause of death, you had to go through a checklist, and that checklist had to be administered by a physician, and the physician had to classify or code the cause of death. And you could have more than one contributing causes to death. So there were a lot of automated algorithms that have been developed that were, because physicians are in short supply, they had this automation to try and solve these problems. And the kind of gold standard data set is something called the public health metrics research collaboration that also includes data that was collected through verbal autopsies in Andhra Pradesh. So verbal autopsy itself has pretty low accuracy. The PHMRC was, somewhat less good than the physician-coded verbal autopsy, and it was kind of the best data set that they had. So when you look at the automated tools that were available, you had data from Brazil, which was from autopsy studies. CHAMPS is a study that is trying to identify the causes of death and stillbirth and early neonatal death in young children. It does this by doing something called minimally invasive tissue sampling, which is essentially doing needle biopsies of multiple organs and then testing to see whether they find a pathogen or a pathology in those organs and use that to code for the cause of death. In India, of course, you had a VA study and you had the PHMRC, which included a site from India. And if you look at the VA software that was available, just looking at PHMRC, you can see that Smart VA was the best of the lot. So now if you look at GPT-4 in the PHMRC data set, they actually found that if you looked at adults, children, and neonates, you had the GPT-4 was almost as good as a physician-certified VA. But this was the best data set available, and it wasn't surprising that the best data resulted in the best accuracy. If you looked at how they could improve the not so good data sets, they looked at the Brazil data set, which I mentioned was based on autopsies, and they found that if you improve your prompting, you can increase the accuracy maybe by about 4 or 5%, but 35% to 38% isn't really the greatest improvement. So the quality of the data that goes into these kinds of studies really does matter. So I'm going to move now into the BMGF AI Grand Challenge. This kind of happened after I got to the foundation. So I was on the sidelines watching all this flurry of activity and people being hired to do all kinds of things. And the idea really was projects that are just for 3 months, they would get about $100,000 as a pilot. It had to be led by investigators in low and middle income countries. And the areas that they were looking at is how do you get from evidence to policy? How do you get from policy to implementation? How do you do decision support, etc.? And the call opened in May of 2023. It was open for barely 2.5 weeks and received over 1,300 applications. There were 1,331 applications received. 643 of them were considered responsive to the call. 550 applications were reviewed, and the ones that had it was a 5-point score, and anything that had a score of 3 or more was discussed. 50 applications were finally shortlisted, and ultimately 1 extra one snuck in there. So 51 were finally reviewed. So if you look at the application dates, this was the pattern by which people had started the application, and everything got submitted, obviously, on the last day. Where did these applications come from? They came from for-profits, universities, and not-for-profits, very few from international organizations and government entities. If we look at where the applications were submitted and where they wanted to do the work, South Asia had a large number of applications, but the bulk of applications really came from Sub-Saharan Africa. If you look at the proposals that had a score of 4 and above, I know you can't read this, but the tallest line is primary healthcare. The second one is global education, and then you have maternal, newborn, and child health as the third category. If you look at the shortlisted proposals, what were they proposing to do about, these are just the score distributions, lots of 4.5s, and about 16 that had a score of 5. If you look at gender of PI, 60% male, about 40% female. Types of organizations reflected the applications, universities, not-for-profits, and for-profit companies. And what they were proposing to use, by and large, 40 of the 51 applications were proposing to use ChatGPT. So where did we wind up with successes? India had 7 proposals that have been supported for funding. Brazil had 6, South Africa had 7. And then the rest are distributed in other places. Overall, again, Sub-Saharan Africa, 29 proposals, South Asia, 12 proposals were funded. Now, of the proposals that are being funded, 75% of them are going to organizations that the Gates Foundation has never funded before. So the idea of at least diversifying the base did work out. So that was a good thing. These are the new ones. This is a new branch, and then existing grantees and organizations were only about a quarter. So moving finally to the summary, where do I think we are at? I think there is a lot of potential, and we and everybody else recognizes this potential. It's important to get your methods right. It's important to work with experts so that you don't start doing the wrong things. Experimentation is important, but ultimately, when you want to check on where you are, we need to make sure that we have very real expertise in the room to see what is being done. If you look at BMGF, their goal is exciting new innovations to try and solve problems that are related to health and development and to scale these kinds of solutions. There is a lot of potential, but if we want to deploy it successfully, it really depends on all of us being responsible and inclusive. If we try to do a one-size-fits-all approach, we are going to fall short because this is a complex area and we need for it to have local engagement. So this current experiment is going to set the base for next steps, so that ultimately where we land up is with insights and not with inequity. So I thought what I'd do is just give you a couple of examples of proposals that got funded. So there is a sense in the room of what areas were covered, what the reviews looked like, and what organizations submitted those proposals. So this one is looking at rural India, developing a model to build frontline health workers. Now, when I read this proposal, I'm thinking, is this nonprofit, non-governmental or charitable organization going to be able to work with the government in rural India in a 3-month time frame to reach 1 million frontline health workers? Anybody in the room think that this is feasible?
Wonder about the 3-month time frame in general.
Well, the 3-month time frame, working with the government of India, reaching 1 million health workers. I mean, I read this proposal and I think, whoever reviewed this is living in cloud cuckoo land. Because they really have no sense of what reality looks like. So maybe that's why I'm at the foundation, to tell them that, some things probably need revision. But this grant actually had an average score of 5. The advantages, of course, were that this group already had some experience and linkages in working with the government. And they thought that the thought processes and permission letters were sufficient to be able to implement this at that level. So some mitigation there. They did think about some of the key aspects. Yes, Pritesh.
Just echo what Rahul just said. 3-month period for implementation of a grant in the settings. I did not even apply because I thought this was disconnected from reality. And do you think that itself is not promoting inequity?
So the idea of the 3-month period is, this is a start. If you can make a good start in 3 months, your progress will be reviewed after 3 months. And then if you need more resources, more funding, that will be made available. It was, if the goal of AI is reach and speed, at least the speed component of what you can do with the tools that you have, if you can make a good start, then we'll see how we can help with the scale. Well, the problem is, who gives the approvals for this project, right? So,
I was just thinking, to echo what I've said about inequity, this will benefit people who are already deep into LLMs and who can just, or maybe who are already in fact working on this and they just get some extra money for doing something that they're already doing. But even so, validating it and so on is going to take way longer than 3 months to get something
of
useful
course,
here.
the idea was very clearly start in 3 months, and then we'll see how to support it further. But you're absolutely right. You can't take a project from start to finish in 3 months. It's not possible.
I just had a more practical question. For projects like this, do we still need to go through something like HMSC, for example?
That's Shinjini's question. Where will your permissions come from? So here, they said that the permission letters are already in place, but people don't understand that permission letter from the government to work with frontline health workers is very different from permission letter to receive international funding from a foreign agency. So that's why I put up an India-specific proposal at the beginning and the end, because I think understanding how an organization that sits half a world away views what it is doing in India might not always be accurate. Okay, this one was a proposal from Uganda. And the idea here was looking at livestock and trying to predict disease emergence. So this was recognized as a high-risk, complex problem, but one with potential for high impact. And here, the only thing that they've got is easily accessible ChatGPT-4. So not necessarily somebody who has access earlier.
I have one more question, sorry.
Yeah.
This $100,000 is not enough to buy a computer cluster to run these LLMs. It will still run on the cloud in OpenAI. So what is this money actually used for?
The money is to identify people that are interested in this area and can formulate a good idea and make a start.
Okay.
So I was actually hoping that there would be more funded projects from India, but perhaps the articulation wasn't appropriate, and I will certainly provide feedback on time and how we could do this differently. Yeah. I know CMC put in 6 applications, 0 funded. So now I want to read those applications and think, were they really that bad? Or, what did the reviews look like? I haven't done that yet.
So the waiting time for OpenAI, ChatGPT, API is more than a year. I applied, I think 6 months ago. So does Microsoft come in and support with their Bing APIs to support the...
If you're IHME, so IHME has this link with Microsoft where they get more computing power than anybody else that I've heard of.
Because Bing, I think, has the GPT support incorporated.
Yeah.
But I'm not sure what the waiting time on that is like. So would that...
I don't know either.
But again, that might be an inequity in the...
So these are the kinds of things that I think really do need to be emphasized, because this is an early stage. If we can be heard now talking about the kinds of problems there are. So within my group, one of the other things that is supported is genomics. And again, genomics requires computing capacity. And in a place where you don't even have the internet, how do you deal with that? So the way the group has been dealing with that is to set up with Starlink to be able to provide for internet in countries in sub-Saharan Africa. But that becomes then a politically sensitive issue. Okay, so yeah, the other examples, looking a group from China proposing talking to peasants for pesticide safe use. I was interested in the terminology that is used because it seems sort of appropriate from the Chinese literature that I have read. Okay, this was another proposal from India, from an Indian university. Actually, it's an Indian university that has links with the US university, and the idea is to look at vaccine development in order to be able to shorten time and save money. So there are challenges with this in terms of what can be done within this space with the kind of approach that they've taken. But as I said, these are really pilots, and we'll see how this goes. So with that, back to the guiding principles, and I'd be happy to talk some more about this or go on to the next presentation.
There's certainly time for more questions, so we can at least another 10 minutes. Are there people with questions? We had lots of them in between. Yeah, go ahead.
Hello, ma'am. So I've been using this IHME site, and what I've noticed is that it tends to miss very rare diseases.
Yeah.
And also like the granularity is not much. Like you'll get country specific, you'll get region specific, but the granularity is not much. So do you suggest how we get to the data of, say, a taluka or
You can't.
very,
Basically, you can't because
yeah.
we don't have data input into the model at that level. So even to go to the subnational level for India was an effort that was undertaken about 6 or 7 years ago. And that allowed for both IHME and another group in Harvard, which is run by S.V. Subramaniam. They do the mapping by parliamentary constituencies and by districts, but you can't go below sub-district. I mean, you can't go sub-district level. You just don't have the data for that. The other problem with IHME is because IHME shrinks everything to the same envelope, you can sometimes wind up for places that don't have primary data, you wind up with attributions that are wildly inaccurate. So for example, in the area that I work in, about 10 years ago, Canada had more cholera than India did, which was interesting. It turned out that 2 people had gone to Canada with cholera. They actually had data from Canada on cholera. And for their population, 2 cases of cholera was a high rate. In India, we reported no cholera, so therefore we had no cholera.
And ma'am, what about the standardization? Like, is the data standardized by population or age, or like there are a lot of groups of...
Yeah, so again, the problem with all of these models is where the data are good, your input data are good, you will get accurate estimates. So Singapore, for example, uses IHME estimates for burden of disease. And for Singapore, it makes perfect sense because Singapore has provided good data. So therefore, the outputs are based on Singapore's own data and are good, right? Even if you provide across vertical programs and IHME integrates, you're not going to be too far off what is real. You take a country in sub-Saharan Africa, you take a country that decides it doesn't want to report a particular disease, you're going to wind up with inaccurate estimates for that country.
In the future, is there like a proposition for going to that granularity and getting the data from?
There's always, so, you know, in India, one of the things we are very good at is absolutely fantastic, detailed policies about what we will do, what is important to do. So we design quite well. We don't execute very well.
Questions? Yeah, go ahead.
Ma'am, a question related to the previous question. So although the LMICs have limited data, but there are issues related to these countries about the underreporting of the data. So whatever the limited data we have, there are always the issue of underreporting because maybe the people are not willing to participate in those studies. So when we do design some study, how do we tackle, and suppose we have to design systematic reviews, how to tackle these arguments? You can't make any inferences because of underreporting, and
inaccurate data is going to lead to your inability to do anything substantial. And in some situations, it's a good thing. You know, if I introduce an intervention, I can claim 100% success if my data does not exist. Right? I introduced a vaccine, I wiped out a disease. How do you know I'm wrong? There's, you know, accurate data is the foundation of public health. We cannot monitor populations. We cannot introduce interventions and measure their impact without measurement. We have to have accurate measurement. Designing it and executing it is, you know, without that, there really is no point in many of the things that we do. There are approaches where sometimes if you have gaps in your data, you can do attributions, you can bridge to other data from similar settings, etc. But that serves us well in very specific situations for a limited period of time. So if there was one thing that I think is really important for India, it is measurement. We can plan on building all the tools and technologies in the world, but if we don't measure accurately, we really are not going to do a good job.
Thank you.
Any more questions? Rahul?
Yeah, I have a question about, well, you talked about building data platforms and LMIC is doing that. So Nikki last week talked about her African data and biospecimen exchange, where they're basically doing exactly that, except it only hosts metadata and not data. So it is basically meant to tell researchers what is available, but connect them if they actually want the data. And one of the concerns that drove this, if I understand right, is that many LMICs, particularly in Africa, have concerns about their data being misused by Western, rich country researchers, or being scooped and taken credit without giving credit to the people who produce the data. So that was one concern. Also, as I understand, it's actually funded by BMGF, so you might know something about it already. Any comments about these concerns? Is it a good idea to just connect the people, the data providers and researchers, instead of actually building a full-fledged data platform that, and of course the concerns about, harmonizing the data standards and interoperability and all that are still there.
So if you had an opportunity to be exploitative, would you choose not to be? Hopefully, as scientists and people who want good for the world, we would choose not to exploit. If you are a company whose responsibility is to shareholders, would you choose not to exploit data? Your choices become harder depending on what is driving you. So I think it's very difficult. Everybody in public health wants global good. How do you achieve that global good as a community together when the incentives are different? For me, as a teacher in medical school, to become a professor, I needed 8 papers, right? And that was it. There is no incentive for me to do more than that. If I am at a medical school in the US and I want to be a researcher, I have to publish in high-end journals, I have to bring in grants, I have to be recognized as somebody special within my field. Those drivers are very different from the drivers for an Indian medical school teacher whose responsibility is primarily clinical care and teaching. Research is a luxury. Research is your bread and butter in the US. So incentives drive the way people behave. And what we try to do is put guardrails around it to try and protect populations, to prevent exploitation. And this is something that requires constant effort.
Yeah, Sarah.
Thank you, Sherry. Really, really enjoyed it.
My experiment worked. Did I tell you a story about the foundation and not my work?
Yes. We discussed yesterday about data issues, which we have. So I'm not going to go ask you a question around it because we had challenges in getting key funded, which is supported by Gates. We couldn't get off the ground. Gautam and Rahul and Uma was involved and Leelavati. Anyway, my question is, if the LMIC focus, and you've been the advisory board for a longer period, a long period, and we discussed about how the growth trajectory for academics, for especially the early career academics, is still not really here in India. Is there a aspiration or direction or push from the advisory committee to address that? I know Wellcome joined up with DBT, and as you said, if we introduce the concept of research at undergraduate level, medical school or STEM subjects, where we need multidisciplinary researchers and a career path, the options still are very limited within India and LMICs. I know global funding bodies are trying to address it. I put in a grant and failed miserably to secure it. Is there an aspiration from Gates Foundation on that direction?
So Gates has traditionally not been a capacity building organization. It's been very much about technology innovation being the solution to global health problems. You know, the cool new vaccine, the cool new diagnostic, the cool new ultrasound, but not so much the people that will deliver those interventions. That's changing. And some of that is, so if you brought up the India Alliance, and there is in Africa a program called the Celestis Juma Fellowships, which have identified 14 really stellar people across Africa. And the idea is to support them in the long term, rather like the Wellcome's bridge from one kind of fellowship to another. In India, there is a proposal to do the repeat Celestis Juma Fellowship in India as something called the M.K. Bhan Fellowships. That has not gotten off the ground, even though it's been several years now. So we can't always blame international funders. We have to fix our processes as well.
Sure, just a quick one. Thank you for that. Very, very thoughtful insights. I'm just picking up from where Rahul asked about data sharing. Now, the Gates Foundation has been funding quite a few for-profit entities in this. How does data sharing work with them? I mean,
Okay, so the Gates Foundation, and I'm still learning, so I may get some of this a bit wrong, but they have different ways of investing. If you are a for-profit organization, the foundation can still invest in two different ways. You can have a contract, well, three different ways. You can have a grant, you can have a contract, or you can have a special investment in the company called a PRI, program-related investment. If it is a grant, the grants for for-profit organizations are a special kind of grant called expenditure responsibility grants. And those require additional legal oversight because the purpose of the foundation is charity, and you have to demonstrate charitable purpose for every grant you give. For a contract, you're buying a service. So the difference is if you fund a for-profit with a grant, then the IP of whatever is generated from that grant belongs to the grantee. If it is a contract, then the IP that is generated belongs to the foundation. Okay, and a PRI depends on the legal arrangement that has been made.
Maybe I can misuse my position to ask one last question. Sure. And sort of one concern when you looked at the techniques these people had done, they're all, I mean, the large percentage, 90% plus was LLMs. I worry a little bit about the fact that, again, related to the hallucinations, you can be very confident about what you predict using these, where the underlying data to anyone who is a specialist on the ground, who's worked on the ground, knows that they cannot be trusted. Yeah. In the cholera example was another, typhoid would be FMD in certain contexts, and there would be another, which is really underreported and will not show up for various political reasons. So I worry a little bit about very confident predictions, which actually should have huge error bars or should not be trusted at all. Yeah. Coming from methods like this and then used to inform policy that will have to be wrong.
Yeah, which is why I think the reviews of the outputs becomes really important, and the right people reviewing those outputs. So I don't think we're at a stage where we can let these out now to be deciding a change of direction or a new policy just based on the outputs of these models.
With that, let me thank Gagandeep again for a wonderful talk, and she'll be around for a little while, I hope, for further questions